Hi, and welcome to everyone joining us today. We'll get started shortly. We're just going to give people a few more minutes to join. So thank you everyone for joining us today. And as you're joining, you can feel free to introduce yourself in the chat. You can include your name, organization, and where you're joining us from. Okay, so we'll just give one more minute before we get started. Thank you, everyone. Okay, we're going to go ahead and get started. So good morning, good afternoon, and good evening. Again, if you have not done so already, please introduce yourself by typing your name, organization, and where you're joining us from into the chat. My name is Sarah Melendez, and I am a Senior Communications Advisor for the HAPPI Consortium and also the Communications Deputy Director of the International Division at JSI. I'm pleased to introduce today's webinar on decision-making considerations and drivers of country-level adoption or switch to a single-dose HPV vaccination schedule. I'll cover some quick housekeeping and review the Zoom environment for this webinar. Please use the Q&A button located at the bottom of your bar on Zoom window to ask any questions or request technical help. We will collect your questions for our speakers and save them for the discussion period following the presentations. This webinar is being recorded, and following the event, you will receive an email with a link to the recording. If there are questions that do not get answered during the Q&A session, we'll share the presenters' responses by emails. With that, I'm pleased to introduce our moderator for today's webinar, Kelly Capellier, the Project Director for the HAPPI Consortium, who will introduce our topic and speakers for today. Kelly Capellier is an immunization technical expert with 20 years of experience in research, program design, implementation, evidence-based decision-making, policy, and management, both in routine immunization and more recently, antigen-specific work, including malaria vaccine, COVID-19 vaccines, and now HPV. All right, Kelly, I'm handing it over to you.
Great. Thank you so much, Sarah, and good afternoon, good morning, everyone. Thank you so much for joining us today to discuss this important topic, especially as we reach the tail end of Cervical Cancer Awareness Month. As Sarah said, my name is Kelly Capellier. I'm with JSI and I'm the Project Director for HAPPI. Today, we'll be discussing the decision-making considerations and drivers of country-level adoption or switch to a single-dose HPV vaccination schedule. This was a global assessment that was conducted by the International Vaccine Access Initiative Center, IVAC, with the Johns Hopkins Bloomberg School of Public Health under the HPV Vaccine Acceleration Partners Platform Initiative, HAPPI, funded by the Gates Foundation. As the data continues to strengthen for single-dose use, there are now 2 HPV vaccine products included in WHO's HPV vaccine program characteristic guidelines that are funded through Gavi for permissive single-dose use. It has been impressive to see just in the last year the acceleration of how many countries have added a single-dose schedule to their HPV vaccination programs, with the potential to strengthen the HPV vaccination program sustainability and coverage through single-dose use. And today we will learn more about what has influenced countries' decisions or not for this switch. We'll spend the next hour discussing this global assessment. I'll start with providing a quick summary of the HAPPI Consortium, and then we'll go into the global assessment findings and leave time at the end for questions and answers. And as we go along, please do drop any questions you might have in the Q&A feature within the Zoom toolbar at the bottom. Next slide, please. So the HPV Vaccine Acceleration Program Partners Initiative, HAPPI Consortium, seeks to contribute to the global HPV vaccination goals, which are the global Gavi's goal to vaccinate 86 million girls against HPV by the end of this year, 2025, and the global goal to vaccinate 90% of girls by the age of 14 years by 2030. And to contribute to this, HAPPI has 3 core objectives. One is to accelerate HPV vaccine introduction. The second is to increase, restore, and sustain HPV vaccination coverage through improved access, equity, and program quality. And then the third is to strengthen the use of evidence to improve HPV vaccination coverage through learning and effective knowledge translation. Next slide. And to contribute to these objectives, we have 5 core focus areas. One is through country technical assistance. We do have a core set of countries that have more focused support and resource, um, which are Nigeria, Pakistan, Indonesia, and also India. And we also have flexible funding that applies to immediate country needs for technical assistance for HPV vaccination programs. We also seek to expand the global evidence base through our monitoring, evaluation, and learning, and to also strengthen the quality of our technical assistance by translating our evidence to practice and use. We also support global coordination efforts, notably through the Gavi HPV vaccine global leadership subteam, and helping to inform global policy and strategy. And cross-cutting through all of this is identifying ways to address gender inequity, social exclusion, and other equity-related barriers for HPV vaccination uptake. Next slide. So the HAPPI Consortium is composed of 5 partners, managed by JSI, with PATH, the Clinton Health Access Initiative, CHI, JPIGO, and through our presenters today, the International Vaccine Access Center, IVAC, at that Johns Hopkins Bloomberg School of Public Health. Next slide. So as we mentioned, the presentation will go through the background, methods, results, discussion, limitations, acknowledgements, and references, and we'll leave time at the end for questions and answers. So once again, please do use the Q&A feature at the bottom of your screen to pose any questions you have as the presentation progresses, which we'll look forward to addressing at the end. And as Sarah said, for those questions that we don't have time to answer, we can address via email. So with that, I'm pleased to present our 3 panelists today, all of whom are from the Johns Hopkins Bloomberg School of Public Health International Vaccine Access Center. Our first presenter is Megan Weissong. Megan is a skilled public health manager with experience in program startup, program management, and research experience within immunization, adolescent sexual health, cervical cancer prevention, reproductive health, and maternal and child health programming. She serves as the program manager and researcher for the HAPPI project and supported the single-dose decision-making study across 19 countries. She holds a faculty appointment at Johns Hopkins University. Our second presenter will be Soan Park, Dr. Soan Park. She is an assistant scientist at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on maternal and child health, intervention, development, and implementation in cervical cancer and HPV vaccination. She's a trained physician. She earned her PhD from the Department of International Health at JHSPH in 2021, and currently she serves as the acting principal investigator for the HAPPI project at IVAC. And our third presenter is Erica Rosser, who is a senior research associate in the Global Disease Epidemiology and Control program at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on global health programs in low middle income countries. She serves as a co-investigator for the HAPPI project and supported the single-dose decision-making study. So very warm welcome to our panelists. And again, thank you to everyone for joining. And I will now pass it over to Megan. Thank you.
Great. Thank you so much, Kelly, and thank you everyone for participating. So let's start with the background and the context in which the study took place. Next slide. So why should we invest in HPV vaccinations? As many of you know, cervical cancer is one of the most common cancers in women worldwide, ranking 4th in both incidence and mortality. Cervical cancer disproportionately impacts women and their families in low and middle income countries where they bear the disease burden of 85 to 90% of all cases. And there's limited access to HPV vaccination as well as screening and treatment services for cervical cancer. In 2022, there were approximately 660,000 new cases and 350,000 deaths due to cervical cancer. In 2020, a global effort to eliminate cervical cancer was launched, with vaccination serving as one of the 3 key strategies for elimination of cervical cancer. This elimination could avert 5 million deaths related to cervical cancer by 2050. Next slide. So in 2022, following emerging evidence of comparable efficacy between single and multi-dose HPV vaccine schedules, the World Health Organization's Strategic Advisory Group of Experts, SAGE, revised their HPV vaccine schedule recommendation for countries to decide between a single or a two-dose schedule for girls aged 9 to 14 years based on emerging evidence of substantial immunogenicity and high vaccine efficacy. The review included 55 studies, including clinical trials from Costa Rica, India, Thailand, Kenya, and Tanzania. The review demonstrated comparable efficacy and effectiveness between single and multi-dose HPV vaccine schedules in preventing persistent infection up to 10 years post-vaccination. Next slide. So what is the landscape of HPV single-dose implementation? As of 2022, more than 50 countries have introduced HPV programs, and at the time of the study, more than 40 countries have reported switching or intend to switch to a single-dose schedule. As of 2024, more than 60 countries have now made the switch. A single-dose regimen could have significant programmatic benefits by reducing both the direct and indirect costs of vaccine supply and improving global vaccine delivery through more equitable access. Next slide. So in terms of the study rationale, given the relative novelty of the permissive single-dose HPV vaccination recommendation by WHO, there is limited understanding of country-level key decision-making considerations, informing the decision to adopt or not adopt a single-dose schedule. So this is why we undertook this study. The aim of this study and our presentation is to assess the key decision-making criteria, including enabling and constraining forces for adopting an HPV single-dose vaccination schedule. Next slide. So we'll move on to the methods for this study. So beginning in 2023, with funding from the HAPPI Consortium via the Gates Foundation, IVAC led a global qualitative assessment to derive the key decision-making criteria, including enabling and constraining factors for adopting or switching to a single-dose HPV vaccination schedule, with data collection taking place from 2023 to 2024. To elicit variation in perspectives, stakeholders were identified in consultation with HAPPI Consortium partners based on the stakeholders' professional affiliation, including Ministry of Health, Expanded Program for Immunization, EPI, NITAG, HAPPI partners, civil society organizations, and multilateral agencies. Trained qualitative interviews conducted interviews over Zoom that took place between 2023 and 2024 to better understand the emergent themes. Next slide. Seeking variation in country characteristics, including program maturity, schedule adoption, geographic region, Gavi eligibility, income status, and cervical cancer burden, we selected countries based on the timing of their HPV introduction and whether they had already made the decision to switch or not to switch to a single dose. There were 26 interviews conducted in countries that have mature programs and are in the process of switching to one dose. 11 interviews took place in countries that will be introducing with one dose. 14 interviews took place in countries that are still deciding or have decided to stick with two doses, and 15 interviews in countries that will be introducing with two doses or are deliberating on introducing with one dose. Next slide. In terms of stakeholder selection, 167 immunization stakeholders were contacted and 66 stakeholders were interviewed. About a third came from the Ministry of Health, EPI or NITAG members, a third from HAPPI partners, and a third from multilateral agencies. Next slide. So there are three key topic areas guiding the discussions. One includes key informants' current role and immunization experience. The next is the current role of the National Cervical Cancer Control Programs. And finally, the factors and forces that influenced HPV schedule decision-making. Next slide. As mentioned previously, data collection took place from September 2023 to February 2024. Stakeholders were mapped and interviewed via Zoom in either English or French, and all stakeholders were identified in consultation with HAPPI partners, sampled proposively based on their professional affiliation to gain variation in perspectives. Additional stakeholders were identified and recruited through referral or snowball sampling from key informants interviewed. In terms of the analysis, inductive and deductive codes were applied to all transcripts in Atlas TI, and salient themes and patterns were identified and mapped to pull and push factors toward and away from a single dose decision. Next slide. At this point, let me hand over the presentation to Erica, who will review the results of the study now. Thank you.
Thank you, Megan. Next slide. Our study interviewed 66 immunization stakeholders across 19 low and middle income countries in Africa and Asia. At the time of this study, 10 countries had already introduced the HPV vaccine on a multi-dose schedule prior to the WHO recommendation for a single dose. 6 of them had switched to single dose. 5 of the remaining 9 countries had either not yet made a decision on the HPV immunization dosing schedule or had chosen to introduce a 2-day schedule. Next slide. We identified 9 factors pulling countries towards a single-dose HPV vaccination schedule. Across regions, stakeholders talked about the motivating influence of robust evidence, the anticipated population health benefits, and the logistical and financial advantages of adopting a single-dose schedule. Next slide. Robust scientific evidence played an important role in countries' decision to adopt the single-dose HPV vaccination schedule. Stakeholders that we interviewed consistently highlighted the strong evidence supporting the safety and efficacy of a single dose compared to 2 doses. This data empowered decision-making bodies, including EPI programs, ministries of health, NITAGs, and interagency coordination committees to confidently explore the benefits of this approach. Next slide. Endorsements from influential bodies like WHO and SAGE triggered discussions and increased country confidence in the single-dose HPV vaccination approach. This was key since single-dose administration required off-label vaccine use. So for many of the stakeholders we spoke with, the WHO SAGE policy served as a credible counter to the manufacturer's positions on licensed dosing schedules. While stakeholders valued the WHO SAGE guidance, they also conducted thorough country-specific assessments to ensure the single-dose approach was suitable within their own context. Next slide. Experiences from countries already using the single-dose HPV vaccination schedule, including high-income countries, significantly influenced decision-making for these low and middle-income countries. Stakeholders emphasized the value of sharing these experiences, particularly within their regions. These reports, studies, and narratives help to foster confidence in the feasibility and effectiveness of the single-dose strategy in similar settings. Next slide. Reducing cervical cancer burden was a key driver for adopting the single-dose HPV vaccine schedule. Stakeholders highlighted the significant impact of cervical cancer on mortality and morbidity in their countries, especially in Africa. As we can see on this slide, a representative from Kenya explained the impact of cervical cancer, saying, "Cervical cancer is a problem in our country, which impacts the household and economy and everything around it." Stakeholders viewed the single-dose approach as an important step towards achieving global elimination goals, and they felt that combined with the global push to achieve the 90-70-90 targets for cervical cancer elimination, HPV vaccination was essentially a low-hanging fruit for prevention efforts, especially compared to the limited cervical cancer screening and treatment available in many countries. Next slide. A key motivation for adopting the single-dose HPV vaccine schedule was the potential to significantly improve vaccination coverage, particularly for hard-to-reach populations. This included out-of-school girls, nomadic communities, marginalized ethnic minorities, and those living with HIV or other immunocompromising conditions. A stakeholder from Ethiopia said, the two-dose HPV schedule is really difficult programmatically, and we are having high dropout rates. We are actually missing vulnerable and at-risk girls, and implementing it with two-dose has reinforced inequities. Those are also considerable issues. So by simplifying the vaccination schedule, countries aim to overcome challenges associated with the two-dose regimen, like missed appointments and logistical hurdles. And they felt that this benefit would be appreciated not only by the people receiving the vaccine, but by implementers as well. Stakeholders also felt that this shift presented an opportunity to potentially expand the program scope to include expanded age cohort vaccination strategies for girls over 14 years of age, or for those who advocated for gender-neutral HPV vaccination strategies, the simplified schedule presented an opportunity to expand population protection by including boys. Next slide. Stakeholders who discussed vaccine price emphasized the cost savings associated with the single-dose schedule. Lower vaccine procurement needs directly translate to reduced program expenses, making the single-dose approach more budget-friendly. This was especially emphasized by countries in sight of transitioning away from Gavi support. Another representative from Kenya explained, Kenya is expected to be self-financing by 2030, and so then the government is supposed to take 100% of the cost of vaccines in Kenya. Therefore, a less costly vaccine or a less costly schedule is welcome if the evidence shows that it is just as efficacious, just as effective, and just as safe. Next slide. Addressing vaccine supply constraints was another key factor driving adoption of the single-dose schedule. Recognizing the ongoing global shortage of HPV vaccines, countries saw the single-dose approach as a solution to alleviate pressure on limited supplies. Next slide. Stakeholders explained that shifting to a single-dose HPV schedule would simplify program operations, eliminating the need for activities like defaulter tracing and maintaining dose registers for subsequent doses, reduces the operational burden on implementers like healthcare workers, who also have to collaborate with schools for school-based delivery programs. It also contributes to cost savings for overall program implementation. Next slide. Stakeholders who discussed stock management and capacity emphasized that the single-dose approach offers significant advantages for stock management and storage, which was particularly important for low-income countries with limited resources. This simplification also streamlined operations and reduced the burden on healthcare facilities, especially those in Africa that were managing multiple vaccine introductions simultaneously. While stakeholders considered these logistical benefits valuable, they were not generally the primary motivator for adopting the single-dose schedule. Next slide. We also identified 4 factors that deterred or delayed countries from adopting a single-dose HPV vaccination schedule, factors pushing them away from this decision. Stakeholders discussed their concerns about the evidence base supporting a single-dose approach, as well as the logistical challenges and financial considerations that emerged during the decision-making process. Next slide. So countries expressed concerns about the limited long-term data on the effectiveness of the single-dose HPV vaccine schedule, the lack of local evidence on immune response and cervical cancer incidence following a single dose of the HPV vaccine raised concerns about the long-term protection offered by a single dose. To address these concerns, some countries plan to conduct further research through their national surveillance systems to evaluate long-term immunogenicity within their own populations. When describing how these concerns impacted NITAG discussions, a stakeholder from Burkina Faso said, obviously, the immunogenicity issue also triggered discussions. What if the vaccine does not produce immunity? This is also, again, why the NITAG strongly recommended a surveillance system that could capture immunogenicity among girls to ensure that they are being protected. It didn't trigger a no recommendation, but it triggered the sentiment that we needed to have the adequate infrastructure to monitor vaccine effectiveness. Next slide. Off-label use of the HPV vaccine was not a concern for all country stakeholders, as numerous countries had prior experience with other off-label vaccinations. However, it did present significant challenges for some countries. Off-label use emerged as a significant hurdle for some Southeast Asian countries. For example, negative experiences with the off-label dengue vaccine, Dengvaxia, slowed decision-making in the Philippines. Other concerns about off-label use of the HPV vaccine included potential liability issues if there were adverse events, and also the potential for increased public apprehension, especially in populations that were already hesitant towards vaccines and the HPV vaccine in particular. Next slide. So effectively communicating the rationale for switching from a multi to single dose schedule, as well as the off-label use, was an important concern for countries with existing HPV vaccination programs. These stakeholders talked about the importance of developing clear messaging, emphasizing the scientific basis of the single dose approach in order to maintain public trust and avoid speculation that the switch was either a cost-cutting measure or that the two-dose regimen had been an overdose. When discussing how to manage these potential challenges, a representative from Laos said, I think the biggest concern is in terms of at the implementation level, how to avoid confusion amongst community members. And not only avoid confusion amongst community members, but it's also to manage the confusion or to come up with standard operating procedures for healthcare providers as well. Next slide. And the final push factor we identified was that while stakeholders felt that switching to a single dose schedule offered long-term cost savings for those with existing HPV vaccination programs that had implemented the multi-dose schedule, there were concerns about the initial costs associated with updating training materials for implementers and communication materials to reflect the new dosing schedule. However, these initial investments were generally considered minor compared to the significant long-term financial benefits of the single dose approach. Next slide. So overall, stakeholders welcomed the single-dose HPV vaccine recommendation, citing twice as many motivating factors as deterrence or practical considerations related to adoption. The most significant motivators were the robust scientific evidence demonstrating vaccine efficacy and safety, along with the strong support from the WHO and SAGE. This strong evidence base provided decision makers with a compelling rationale for adopting an approach which they anticipated would yield significant public health benefits, including increased population level protection against cervical cancer and improved vaccination program coverage. Next slide. And now I'll turn it over to Celine.
Thank you, Erica. So here are some discussion points. Next slide, please. Decision to adopt or switch to a single dose reflects an interplay among three factors. First, potential public health impact on cervical cancer mortality and morbidity. Second, scientific evidence, including effectiveness, non-inferiority of single dose relative to two-dose regimen, safety, and immunogenicity at population level. And third, programmatic, logistic, and financial benefits, including the potential to vaccinate more girls and achieve higher vaccination coverage. Overall, stakeholders reported that they anticipate benefits of adopting a single-dose schedule outweigh the associated risks, costs, and challenges. Next slide. The lessons learned from the study can be summarized into the 5 points. First, drawing parallel to precedent off-label use of other immunization products, for example, fractional inactivated poliovirus vaccine, may address reticence towards single-dose HPV vaccination. Also, rapid synthesis and dissemination of emerging single-dose evidence can build confidence in single-dose HPV vaccination. Localized, contextualized, and tailored communication strategy would address misconceptions related to single-dose HPV vaccination in different audiences. Sharing lessons learned from implementation of the single-dose vaccination, especially in neighboring countries, can increase confidence in adopting a single-dose schedule. Finally, potential costs averted from a switch from 2 to 1 dose schedule should be reinvested within national HPV vaccination programs. Next slide, please. Despite these interesting lessons learned, our study has some limitations. First of all, interviews were cross-sectionally conducted. Thus, the findings may not capture evolving landscape of HPV vaccine schedule decision-making drivers. Also, the findings may not be transferable to stakeholders and countries that are not represented in this study. Finally, although we ensured confidentiality, stakeholders may have self-censored and avoided disclosing sensitive information about single-dose decision-making. Next slide. This study could not have been done without participation of the key informants and stakeholders. We would also like to extend our gratefulness to our partners and support from the Sheikh Gates Foundation, WHO, and Gavi HPV sub-team. Thank you. These are the references. Kelly, it's over to you now.
Great. Thanks so much, everyone. And thank you for this presentation. So now that brings us to our question and answer part of the webinar. And if you do have any questions that arose during the presentation, please do feel free to drop them in the Q&A. And we have a first question in the chat. This is actually from us, and curious from those of you participating. If you are part of a decision-making body, or did you not have the resources to be able to make an informed decision to switch to a single dose? And so you can either raise your hand and come off mute, or put your answer in the chat. But we are curious that while many countries have decided to switch to a single dose, and there are only a few countries left that have not, especially in Africa, we are curious if is the evidence there and is it adequate? We just heard from someone that having rapidly synthesized evidence has been an enabling factor for being able to make a rapid decision for single dose use. But was the evidence adequate? What's needed to be able to make a more informed decision? Okay, so if anybody has any reflections on that question, you're welcome to type those in the chat. Thank you. And so I just had a question for the panelists as well. And the study mentioned that decision makers value learning from the experiences of other countries with single dose HPV vaccination. How were these lessons typically shared, and which formats were most preferred by stakeholders? For example, was it testimonies, published literature, case studies, workshops, etc.? Thank you.
I can answer that one, Kelly. So Stakeholders didn't really reference individual testimonies, but they did talk about being sensitized to other countries' experiences with single-dose HPV vaccination at regional meetings. I specifically remember people mentioning the impact of their participation in the Coalition to Strengthen HPV Immunization Community, the SHEIC Africa Symposium, which was held in Ethiopia in 2022, I believe. Several people mentioned that as an event that exposed them to the single dose schedule. Stakeholders, they also referenced the influence of data from clinical trials conducted in countries like India. And multiple stakeholders cited publications detailing the outcomes of Australia's experiences with the single dose HPV vaccination. So, according to the stakeholders, these collective experiences and evidence from various sources contributed to their growing awareness, understanding, and acceptance of the single dose approach.
Great. Thank you so much, Erica. Okay, I don't see any other questions in the chat. So the study also highlighted the role of technical partners in gathering evidence for national decision-making bodies regarding single-dose HPV vaccination. Did stakeholders discuss the type of support they would find most valuable from partners during the implementation phase of the single-dose schedule?
There was some conversation about that, yes. So in the presentation, I talked about the concerns of stakeholders with existing HPV programs, HPV vaccination programs. These stakeholders had already invested significant effort and resources into developing and disseminating training materials and public communication materials aligned with the previously recommended two-dose schedule. So for those stakeholders, they suggested that support from technical partners with updating materials for the public and training sessions for implementers to reflect the new single dose schedule would be appreciated. Let me think. Right, so they said that they would appreciate assistance with providing training sessions for program implementers to equip them with the knowledge and the skills that would be necessary to effectively implement the revised single dose schedule and to answer any questions or concerns that they might have and to discuss how to adapt their program strategies accordingly. And they also noted that by providing this kind of support, technical partners could help to ensure a smooth and effective transition to the single dose HPV vaccination schedule while minimizing any disruption to existing programs and maximizing the impact of these critical public health interventions.
Great, thanks so much, Erica. And I do see in reference to your final point there is a question in the chat about when are you going to train healthcare providers on the ground about single dose vaccine? So I would say this is probably a question for national immunization programs. And if it's a resourcing question, there are resources available for that support. But otherwise, this would be part of the planning in the single dose adoption for each country level and contingent upon planning within the national immunization program. Okay, so there are a couple more questions in the chat. How can we convince the pharmaceutical company to adopt the single dose and amend its CPR? So that's a great question. We do know that Merck is making efforts to compile it. They'll be implementing a clinical trial to compile its own data around single dose use for updating its CPR. But otherwise, that's a question that we can't necessarily answer right now. But the good news is we do have data available through several studies, clinical trial data available through several studies that support the sustained immunity for single dose use. And then Brian has a question that's in the chat. Thank you so much, HAPPI team. During the study, there was any observation or indications on whether countries would change how they deliver HPV vaccine, for example, school versus facility, as a result of switching to a one-dose schedule? It's a great question, Brian. I'll turn it over to the panelists.
Yeah, thank you, Brian. That's an interesting question. I don't recall anyone talking about switching their strategies for vaccine delivery. Primarily, countries were using school-based delivery. They also talked about facility-based delivery and some outreach efforts that they made. But the conversations were about how the single dose would simplify the strategies that they were already implementing rather than changing strategies based on the new schedule.
So,
did you want to add?
I was going to answer the next question in the Q&A. Yeah, countries that have achieved high coverage with two-dose schedule, is there a benefit in switching to single dose? Yeah, if countries that achieved high coverage with two-dose, it seems like they may think that there may not be benefit in switching, but based on our study, there are many benefits that Erica already explained in the results. For example, the lowered procurement cost, that's an important one, especially in the resource-limited settings. And this also leads to an opportunity to expand the target population of the HPV vaccination for older girls who missed their vaccination during the age between age 9 to 14, and other. We could expand. Think about the opportunities to expand the target population to boys. So this can be another opportunity after the switch. Erica or Megan, do you want to add?
No, I think you covered it well.
And I think to that question, so for countries who had expressed concerns and challenges around technical legalities of the move to one dose, are there examples of what countries need to overcome this?
Can you say that again, Kelly? What was that?
Yeah, for countries who had expressed concerns and challenges around technical legalities of the move to one dose, are there examples of what countries need to overcome this?
Erica or Megan can add, but mostly the decision from the NITAG, that's how they interpolate with the internal challenges. Like if NITAG had a strong recommendation, then they could, the legal challenges could be discussed within the governments.
Yeah, I think that people who had concerns about those kinds of challenges felt that what they needed was for the manufacturers to change their recommendations on the scheduled dosing. Perhaps also as additional countries roll out single dose, and if they are able to share reports on their experiences and successes, that might help as well. But that was the primary feedback that we received, was wanting the manufacturers to change their recommendations.
Thank you. And did you come across any evidence that a switch in program has already potentially contributed to vaccine hesitancy in the countries that had already switched?
Yeah, that's an interesting question. Megan, you can add in here as well if you have anything. I don't recall anyone mentioning that the switch to single dose had contributed to vaccine hesitancy, but there was a lot of conversation with stakeholders in Cameroon. I remember they they were very conscientious about including different types of stakeholders throughout their decision-making process in order to really build a coalition, a cohesive group of support at all levels for the vaccine. And some of that was because they had had vaccine hesitancy in the population when they had initially implemented the 2-dose schedule. And so when they were talking about switching to single dose, they really wanted to make sure to take advantage of all of the collaborations that they could, to think in advance about what might be potential reasons for vaccine hesitancy and how those might be addressed, and to start working on discussing and reflecting on that very early in the decision-making process.
Maybe just to add, I didn't hear of any issues around misinformation, but I think the point that Erica made in terms of being very thoughtful in who was part of the discussions, as well as retraining the immunization teams so that they would be able to counter the myths and misconceptions during the immunization and during the launch was really important. But I think there was anticipated issues around myths and misconceptions that the single dose, but nobody reported that that was actually the case.
Great, thank you. I mean, it's interesting. It kind of goes into the planning, right? Because it's a fair point and a fair question around, how can reducing the number of doses impact hesitancy or uptake of the vaccine? So ensuring that health workers are a key stakeholder in that process and planning, and also in communications, is critically important. Okay, there are a lot of questions in the chat, so my apologies for not keeping up. Did key informants mention drivers of single dose adoption from a policy perspective?
That's an interesting question. I'm not sure what an example of that would be from a policy perspective. Megan, do you have any insight on that?
Maybe whoever wrote that in can add to their question. Or come off mute to mention that a little bit further.
Okay. All right. Well, that's something we can follow up on, or if the person who wrote that in the chat would like to expand upon it in the chat. Another question, were there any countries that required additional vaccine registration steps or processes in country as a result of the off-label use? So through the NRAs, for example, this might help countries planning launches soon, in case there are regulatory registration hurdles to manage.
Yeah, that's an interesting question, Megan. I think you might have done more of the interviews from Southeast Asia. Do you recall anyone discussing that?
I think it was raised as a concern, but I don't think they went into details of how they had to overcome the off-label use, because I think they were still deliberating on that issue in terms of making the decision. But I don't remember specific details of what hoops they needed to jump through to make that decision.
Yeah, I think the main point was that there were delays and bottlenecks at multiple levels, including regulatory levels that were slowing down the decision making around single dose because of the off-label use.
It's a great question. It's actually something that we're frequently asking ourselves. And I know we have a lot of colleagues and members of NITAGs that are on the call. If anyone has any insights and would like to come off mute, what your country experience has been and whether or not there's been some regulatory hurdles or challenges with off-label use, or if you'd like to put something in the chat, it'd be really interesting to understand what the regulatory pathway has been towards single dose adoption. Anyone interested in coming off mute and giving your country experience? Okay. Yes. Oh, okay. Oh, nice to see you. Please go ahead. Tell us about Ghana.
Hello. Thank you. Yeah. And I'd like to thank the presenters for very interesting information. Yeah, Ghana is yet to introduce, but then what HPV vaccine has been on the drawing board for more than 3 years, and it was all due to financing, the cost, and especially in view of the fact that we are also, Ghana is heading towards graduation. So it became quite difficult. And in the transition plan to graduation by Gavi, yeah, it was factored into the plan because the interest to introduce was there, but then the constraining factor was the financing. So eventually when a single dose became possible, and especially with the same efficacy, and then it also reduced the advantages was obviously very appealing. So it motivated us to push for that. And that is why initially we had, or in our planning, we were planning towards a 2-dose. But as soon as this became possible, we felt it's an opportunity and we are moving towards a single dose adopting a single dose HPV in the country, though we are yet to fully get on board. So that is how Ghana's experience. The cost was really a barrier. Thank you.
Great. Thank you so much, Keo. So we're coming up on our time here, and I know that there are several questions we haven't answered, which we are happy to answer via email. I know there was a question about high-risk groups, such as those who are HIV positive, and whether or not the dose or the schedule is different. The schedule remains the same for high-risk groups. This single dose schedule is for recommended for girls who are not high risk or not HIV positive. And I know there were other questions. There was whether or not there was a only bivalent vaccine. So the two products that are supported by Gavi that are within the WHO guidelines are the Secalin Innovax product and also the Merck Gardasil 4, and then Gardasil 9, but that's not supported through Gavi. So this concludes our webinar. Thank you so much to those who, many of you who participated today, and to our panelists and to IVAC for a really engaging presentation. Thank you. And Hope also has put in the chat the FAQ around single dose evidence and policy, which is a very useful document, by the way, if there are interest in the different evidence available for making a decision. So I think that a few of the key elements that we learned today is a single dose has the potential to really help improve coverage, but also reach more girls and also improve the affordability of the vaccine at country level and ease and the efficiency of program implementation factors. And we really appreciate that all of the countries and the participants who participated in this global assessment to help us better understand what the factors are for moving toward a single dose decision or not. So thank you again, and please do know in the chat the resources that are available. You're welcome to reach out, and we're happy to to provide any additional resources or questions you might have. So wishing everyone a wonderful end of the week and a day or evening, no matter where you are in the world. Thank you.